Good morning, everyone, and thank you very much for inviting me to speak today. I'm going to be speaking about emerging technologies in the imaging of small renal masses. My name is Navin Ramachandran. I'm a radiologist at UCLH and the Royal Free. So let's dig in straight away. So first, before looking at this, we should think about how we actually assess small renal masses. And here's a little algorithm most of us tend to use. You have a pretest probability, any risk factors. Then you look whether it's solid or cystic. Are there any benign or sinister features associated with the lesion, apart from being solid or cystic? And then once we have that, we decide what we do next. So if it's solid or Bosniak 2F/3 or above, we take it to the MDT. And if not, we don't investigate any further. So when you're looking at your pretest probability, let's go back to that. Pre-test probability, one of the things you look at is genetics. So if they've got VHL, tuberous sclerosis, Berthold de Bay, HLRCC, or hereditary papillary RCC, then we are obviously a bit more worried. And any smaller lesion, if it's indeterminate, we still pursue more aggressively. The next thing is looking whether it's solid or cystic, and the best modalities to do this are probably T2 MRI and ultrasound. Ultrasound's pretty good at this, and I think it gets overlooked quite often. So on this, usually you can tell whether it's solid or cystic. Even if it's solid, what you want to know is it clot or is it enhancing? So enhancement's that probably the thing we look for the most to tell us that there's something to worry about. And obviously if it's solid, it's more worrying. If it's cystic, we're a bit more relaxed, but we look for sinister features. So is there a nodule? Is the wall thickened at all? Are there septations? Is there enhancement, again, of these features? The last thing is we look for calcium. So traditionally we've used that as part of the Bosniak classification, but actually we'll get to that later. We're not as worried about that at the moment with the new guidelines. So if it is solid, are there any benign features we can look for? So fat, essentially. So fat makes us think it's an angiomyolipoma. There's one small caveat there. The caveat is that if there's fat and calcium, it's unlikely to be an angiomyolipoma. And we start thinking about metaplasia, and you can get bone marrow metaplasia in some renal cell cancers. So if you get fat by itself, AML. If it's fat and calcium, you think it's a bit more suspicious for an RCC. So the other thing we often gets quoted as a central scar of an oncocytoma, but this is a highly unreliable sign. We often see oncocytomas without a scar, and we often see RCCs with something that looks like a scar. So moving on, when we get that, we have a standard pathway for assessment of most lesions. So most lesions tend to get found as an incidental finding on ultrasound, MRI, or single-phase CT. And our traditional way is to say, okay, what's the simplest thing that will pick up and correctly characterize lesions? It tends to be a triple-phase CT. But if you're young, pregnant, or have a contrast allergy, or you have renal failure, then we go to MRI. And then we can take them down different pathways. So let's look at what we're doing here. So the modalities we're looking at. Why triple phase renal CTs? Well, we use in most patients because it's the best thing to reliably see fat and calcium. And it's the best thing to quantifiably measure enhancement to see whether it is proper enhancement or pseudo enhancement. So if you can confidently say there's enhancement, you're a bit more suspicious that it's nasty. And if you think there's fat, then you're more likely to think it's benign. And calcium, we've talked about before, why that's useful. So MRI, we give with contrast in younger patients, contrast allergies, and we often use it now for lesions where CT is indeterminate and we're not sure whether something enhances. And that's often with papillary tumours. So poorly enhancing papillary tumours are incredibly hard to find, and actually even with a CT scan there's something it's hyperdense. It doesn't quite enhance, but we, especially in younger patients, we tend to pursue those more aggressively and look with either ultrasound or MRI to see if they do enhance. So the problem with MRI is that calcium you don't see reliably, and fat can often be misdiagnosed or overdiagnosed on MRI. So I think you've got to be very careful with that. So that's your bog standard stuff. In some centres, you go a bit further. So at UCH and a couple of other centres, we offer contrast-enhanced ultrasound, and actually this is we're finding to be an incredibly powerful modality, because not only can you see with something cystic, but
in this
you
video
can
clip,
also
we have played
see
the
the
sequence
enhancement
over
in
and over again, as the blanching
what
flare
we do
is so
see
rapid it can be easily missed.
is
We would now like
that
to demonstrate
it's useful for targeted ultrasound of a particular
with injection
lesion.
of the
Trying
ultrasound
to
contrast
assess
material,
both kidneys
the more
with
cranial,
contrast
diffused
to
portion
spot
of the
lesions
kidney
is
is seen to
incredibly
light
difficult.
up
So what
with
we do
increased
is tend to
echogenicity
reserve that
caused by the
for
solidity of
lesions which haven't been
microspheres.
adequately
There is a clear
characterized in other
demarcation or
modalities.
watershed between
It's also
diffused
used
and non-diffused
intraoperatively
portions
to
of
see
kidney.
the margins of
This
the blood supply and to
demarcation
see whether you've
extends right into the
appropriately
depths of the
devascularized a
parenchyma.
region before you take a tumor out. So there's a nice video from there. What we're often using more to plan operations for tumors that involve the vessels is CT venography or MR venography. MR in particular is very good at telling you exactly how far the tumor extends, and also it tells you whether the tumor enhances, whether the thrombus enhances. So is it bland thrombus within the renal vein or IVC, or is part of that or the entirety of it actually tumor thrombus, which you'd obviously treat more carefully. Now, any more than that? Well, traditionally I've said the PET scan tends to be not very good at differentiating renal tumors. So there's been lots of different traces tried, and actually it doesn't do so well at differentiating benign from malignant or different tumor types. But we're starting to see some benefit of using sestamib. So sestamib is a pretty bog standard nuclear medicine agent that you give for assessing lots of different things, including the thyroid, the heart. We've seen that it actually has a much higher uptake in oncocytomas versus RCCs. The picture on the left, the very well labeled one, is from the paper from the Journal of Nuclear Medicine in May 2020, showing the increased uptake in the oncocytoma. And actually on the right is the first image we have of the first patient done at the Royal Free using this technique, and we're quite excited about that. It's showing quite a lot of promise. And this doesn't necessarily give you the answer, but it helps to risk stratify the patient in terms of operations versus monitoring. So the other, I don't want to call it sexy, but the other novel technology that's being developed right now, and there's a scanner set up at UCH, is hyperpolarized MRI. So hyperpolarized MRI is equivalent to PET in some ways, in that you give different metabolic agents. So in this case, there's pyruvate, lactate, alanine, bicarbonate, and then you inject that and you scan them with an MRI scanner, and you see activity of that or uptake of that agent in different tissues. So you can see pyruvate has great uptake in the kidneys, and there's initial work being done around looking at how that changes within renal cell cancer. The advantage of this over PET is that there's no radiation dose with any of this. But again, this is early work. The truth is, when you talk about the most important development in the last 2-3 years in terms of imaging, it's actually not a new modality. It's the Bosniak 2019 guidelines. And this has been, we've adopted them, and in our MDT, we've switched from the old guidelines to this, and it's made a big difference. What tends to happen with the old Bosniak classification is that it was not very well, it's not very reproducible, is probably the best way of putting it in there. It's kind of vague descriptions of different kinds of lesions, and you try to characterize your lesion of interest into one of those, whereas there were no concrete measurements you could take. This time round, they've made measurable aspects of it, so you can measure the width of the lesion wall is the top image. You measure the width of any septa in there, and then that gives you different classifications. You measure the nodules arising from the walls or from septa, and again that gives you different Bosniak classifications. Also very good in this is that the original Bosniak classification only worked for CT, whereas this also works for MRI. And what we're tending to find is a very positive impact. In fact, I forgot to mention probably one of the most important things. One of the commonest reasons that we used to follow up lesions according to the old Bosniak classification was due to calcification within the lesion. And most radiologists have always wondered why, because it just didn't make much sense to us. Because pretty much all of these were down to old hemorrhage calcifying. And personally, I've never seen one ever progress from a calcified lesion cyst towards a full tumor. And with this new classification, calcification does not count as a sinister feature. So lots of scans that we've seen that were previously 2F have now been downgraded to 2, and that means a much smaller follow-up burden. But that also has a great knock-on effect in that your MDTs and the burden on the whole system is much lower, and the care you can afford to the other lesions is it's much better funded, both in terms of money and time. So I think you end up with a much better service by getting rid of the noise and concentrating on the signal itself. So that, to me, has probably been the most interesting change in the last few years. But the last thing I want to touch on, this is a personal favorite, and I think Faze as well has a big interest in this. It's how you communicate complexity when you got these small masses, because this is how we see that traditionally. We go, okay, how do I say if something's important, it's going to be complex to operate on. You use either the Padua score or the renal score, and here's an example of the renal score, and it's very good in that you can say roughly where it is in the kidney, how big it is, how close it is to vital structures, and then decide how complex an operation will be. That's good for guessing complexity, but it's very poor at relaying the exact nature of the complexity sometimes. So examples like this, how do you account for multiple vessels like this feeding one kidney? How do you account for a horseshoe kidney and describing the position of that lesion in that kidney? The reality is text and manual descriptions are kind of useful only to an extent. So then we decide to look at can we actually provide a representation that a surgeon can look at and easily get a mental model of before the operation. So we started looking at 3D volumetric reconstructions of the organs straight from the CT data. But you can see the computer and the image has no idea of what a structure is. It just knows that it's of a certain density, so it goes, well, I'll color everything the right way. So it's a bit of a jumble to pick out, and there's no way to pull these things apart to get a better look at it. You just end up with a blob that you can kind of rotate round and not do much more with. So what we've been looking at recently is a more complex way of looking at it, where you say, okay, you use an AI algorithm that's been trained to specifically pick out the IVC in veins, the artery, the aorta and all the arteries, different organs, especially the kidney, and within the kidney you start picking out, okay, here's the collecting system, here is the tumor or any lesions of interest. And once those are mapped out, then they become individual 3D models that can be pulled apart, rotated individually, so you can get a real idea of what the anatomy looks like before you operate. So this is something with Faze and the group at Innosight Labs we put together with the HoloLens a couple of years ago. I always show this, but it's a great video. And I think this is probably going to be the future of preoperative planning, where you can say, okay, before I operate, I will get a very good idea of what's happening here, and then tuck in and do the operation. So I think assessment of renal masses overall, I think the main issue is I don't think we'll ever get away from the fact that these tumours are very heterogeneous. And when you've got so many different tumour subtypes, it's very hard to differentiate benign from malignant masses from here. I think you have to keep it pretty simple and say, okay, is it solid? Is it enhancing? If so, and we're worried, then you have to biopsy it. Or the vast majority of lesions, we tend to biopsy now to get an idea of what the tumour subtype is and the grade. And I think it's going to be very difficult to get past that in the kidney, mainly because of the heterogeneity of the tumours, not just the different types, but also within a lesion, you can get heterogeneous lesions. So you can get hybrid tumours of oncocytomas and RCC, and you can also get different aggressions and different grades within a certain tumour. So I think it's very hard to get past that with imaging alone. I think what we should be concentrating more on is trying to get rid of all the noise, like all the Bosniaks, get rid of them. Start seeing, is there anything that can risk stratify, like sestamib, biopsy obviously, and then when we decide to intervene, are there ways to improve the operative outcomes by just information flow? So talking about the complexity of the case. Thank you very much.